This program is brought to you by Community Trust Bank, Medical City, Bid Select, and the Neely School of Business at TCU. Welcome to Platforms, the life-lifting news program for women. Now, here's your host, Siobhan Palmer.
Hey, welcome everybody to Platforms, the life-lifting news program for women. We're talking this week about a very hot topic in healthcare, minimally invasive surgery, and I'm absolutely honored to introduce our next guest. Dr. Mitch Magee is cardiac thoracic surgeon here at Medical City, Dallas. Dr. Magee, welcome.
Thank you. Pleasure to be here.
We have had a great show talking about this topic, and I really, when you were talking earlier, I think the general public has many misperceptions about that term, minimally invasive surgery. So why don't you kind of spell out the reality of that?
Sure. Well, minimally invasive surgery is a buzzword, I think, in medicine today. It's a hot topic. Everybody's interested in having less invasive surgery, if it can be less invasive. And I think the definition of less invasive or minimally invasive surgery varies from specialty to specialty and from individual to individual. How we define that is very important for the individual too, because we want to make sure that our goals in achieving minimally invasive surgery are the same.
Right.
The expectations of the patient meet the expectations of the surgeon.
How do you determine, I mean, when you're talking to patients and everything, what criteria do you look at in your particular specialization, and whether you're going to go that way or conventional surgery?
Well, a friend of mine who's also a thoracic surgeon kind of defined it in this way at a meeting that I was at. There's conservation of energy whenever you have an operation. If you take away the pain from the patient, it gets transferred to the surgeon. So the less invasive an operation is, and the less pain or the less time to recovery that a patient has after an operation or during an operation makes it that much more challenging for the surgeon to perform. It's always difficult to do the same operation through a smaller incision with less visualization, with less control than it is through a big incision.
Yeah, makes sense. So, and relative to your particular specialization, I know you and Dr. Dewey are colleagues, but you share different subspecialties. Tell our audience what those are for you.
Well, we are both cardiothoracic surgeons, which means that we have been through medical school. We then complete an internship, and then 5 years to 7 years of general surgery training, and then another 2 to 3 years of cardiac and thoracic surgical training. So it's for me, it was 10 years after medical school and training in an on-the-job type of training. And then after that, I then subspecialized in an area of thoracic surgery, which really focuses on thoracic oncology. Now, thoracic surgery, thorax refers to the chest. Okay. So it's really anything from just below the neck down to the diaphragm, and in my case, it goes a little bit below the diaphragm to include the stomach, or what we call the foregut, which includes the esophagus and the stomach. So any tumors that occur in the chest or originate in the chest and spread outside or are contiguous with the chest is my area of specialization. And so lung cancer is a large part of what I do.
Wow.
Lung cancer is a huge growing health problem. Despite a decline in smoking, the incidence of lung cancer is rising in non-smokers.
What's it attributable to?
Well, like a lot of things in medicine, it's genetic based essentially. The risk of developing a lung cancer is largely due to your genes.
See, now that is something remarkable you just said, because I think most people just associate lung cancer immediately with cigarette smoking.
Absolutely.
So it's based on genes.
Well, as I said, despite a heightened awareness of the hazards and risks of smoking and the associated health risks associated with smoking, and a decline in smoking and cigarette use, the incidence of lung cancer is rising and continues to rise. And unfortunately, the deaths related to lung cancer have been fairly static over the last 15 to 20 years.
Wow.
The decline in mortality from breast cancer has been dramatic. And same is true for prostate cancer, but not true for lung cancer. Lung cancer kills more men than prostate cancer, more women than breast cancer. And in fact, the top 3 cancers combined in both men and women. So it's a rising health problem. Related to minimally invasive surgery, one of the things that I do as a specialist in the care of patients with lung cancer as a surgeon is a minimally invasive approach to treating lung cancer.
How would you, that's remarkable. So give us an example. What would you do for?
So as I alluded to, anytime we do minimally invasive surgery, it should be the goal of your surgeon to perform the same operation through a small incision, through a less invasive approach than they would in an open setting. You don't want to compromise the operation just to make it cosmetically better,
Exactly.
or give the patient less pain and a shorter recovery. Those are good goals to have, but you don't want to compromise a cancer operation, particularly in achieving a less invasive approach. So you want to make sure that you're doing the same safe and effective cancer operation through a less invasive approach. And less invasive lung surgery involves not spreading the ribs, using a very small incision, minimizing the amount of muscle that's cut, and basically doing it through keyhole surgery. 3 small incisions, slit-like incisions between the ribs, not spreading the ribs, which decreases the amount of pain associated with the operation and shortens recovery. The average stay in the hospital after a minimally invasive, what we call thoracoscopic lobectomy, is about 2 to 3 days.
2 to 3 days. That's
right.
remarkable.
And back to work within 2 weeks, or back to normal activities within 2 weeks, as opposed to 4 to 6 weeks with a standard open approach,
Right.
and typically 5 to 7 days in the hospital with an open approach.
I'm going to ask a real stupid question, but that's my job. When you go in minimally invasive for lung surgery procedure, do you have to inflate that area of the chest like you would the abdomen for the surgeon to actually, or do you not have that luxury because that's a closed-in area? I mean, is that a stupid question?
Sometimes we use insufflation in the chest, as is done with laparoscopic surgery
Right.
in the abdomen. Most of the time it's not necessary. Okay. When we work in the mediastinum, which is the area behind the breastbone and in front of behind the breastbone and in front of the heart,
Right.
we do use CO2 insufflation, or the same type of inflation that's used with laparoscopic surgery. When we're operating on the lung, it's not as important, it's not necessary, because we actually deflate the lung. So that creates the same space just by collapsing the lung intentionally.
Yeah, makes total sense.
That makes the CO2 insufflation not necessary.
It's fascinating information. One of the areas that a couple of your colleagues touched on is that there are challenges when you're operating on obese patients, because obviously, is that something that, obviously that's a thing you have to take into consideration before you even approach the operation by someone of normal weight?
Well, obese patients do have present unique challenges in terms of being able to do less invasive surgery. But on the other hand, in some ways, less invasive surgery is easier still than an open operation. Open surgery is equally challenging, and in some cases more challenging than a less invasive operation. So it really depends, again, on the patient, their specific features, body habitus, and the type of surgery that you're planning on doing. In some cases, it's still feasible.
Right. Dr. Hold, I thought we're going to come back after a break. I'm here with Dr. Mitch Magee, cardiac thoracic surgeon at Medical City, Dallas. We're talking about minimally invasive surgery, and we'll be back in just a moment.